Coming to the next set of charts. Coming to HOCM, that is hypertrophic cardiomyopathy. In all patients, evaluate the risk of sudden death. If high, consider ICD. If low, follow with serial evaluation. If patient is symptomatic, you have to do all this. If the patient is asymptomatic, you have to do all this. If there is evidence of fluid retention, use diuretics with caution to avoid hypovolemia, particularly in the presence of outflow gradient. If the patient is symptomatic, titrate beta blocker and calcium channel blockers. If the still symptoms persist, if there is any outflow gradient, try disopyramide. Presence of refractory severe symptoms, consider septal ablation or mitral surgery. If there is no outflow gradient, evidence of severe progressive valvular dysfunction, reevaluate cause of symptoms, rarely consider cardiac transplantation. Causes of restrictive cardiomyopathy infiltrative between myocytes. Amyloidosis is primary light chain transport, familial abnormal thyretin, senile normal transthyretin or atrial peptides, inherited metabolic defects. Storage disorder is within myocytes, hemochromatosis, inherited metabolic defects like Fabry's disease and glycogen storage disease like 2 and 3. Fibrotic is radiation and scleroderma. Endomyocardial is possibly related to fibrotic diseases like tropical endomyocardial fibrosis, hypereosinophilic syndrome, that is Loeffler's endocarditis, carcinoid syndrome, radiations and drugs like serotonin and ergotamine. Overlap with other cardiomyopathies like HOCM and pseudohypertrophic, minimally dilated cardiomyopathy, early stage dilated cardiomyopathy, partial recovery from dilated cardiomyopathy, sarcoidosis, and idiopathic. So this is a very important chart, difference between dilated, restrictive and hypertrophic cardiomyopathy. Ejection fraction is usually less when symptoms are severe. Restrictive it is 25 to 50 and hypertrophic it is usually greater than 60. Left ventricular diastolic dimension is more than 60, and in case of restrictive and hypertrophic it is often decreased. Atrial size is increased and dilated, increased and may be massive in the restrictive, increased related to elevated filling pressures. Valvular regurgitation for dilated is related to annular dilatation, so MR occurs. Tricuspid regurgitation with right ventricular dysfunction. Restrictive is related to endocardial involvement, frequent mitral and tricuspid regurgitation, related to wall septum infarction, mitral regurgitation. Common first symptoms: exertional intolerance in case of restrictive, and hypertrophic exertional intolerance may have chest pain. Congestive system, left before right except right predominant in young adults, and the restrictive it is right often dominates, right side failure, and hypertrophic it is always left sided congestion at rest, may develop later. Arrhythmias, ventricular tachyarrhythmias, conduction block in Chagas disease, in some families atrial fibrillation in case of dilated. Restrictive is ventricular common except in sarcoidosis, conduction block and atrial fibrillation. And again, hypertrophic is ventricular tachyarrhythmias and atrial fibrillation. Principles of ICD implantation. Intracardiac defibrillator for primary prevention of sudden death. If arrhythmia, sudden death mismatch, sudden death in heart failure patients is generally due to progressive left ventricular dysfunction, not a focal arrhythmia substrate, except in patients with post-MI heart failure. Diminishing returns with advanced disease, intervention at early stages of heart failure most successful since sudden death diminishes as a cause of death with advanced heart failure. Timing of benefits: left LVEF should be evaluated at optimal medical therapy or after revascularization before ICD therapy is employed. No benefit to ICD implant within 40 days of an MI, unless for secondary prevention. Estimation of benefits and prognosis. Patients and clinicians often overestimate the benefits of ICD, and ICD discharge is not equivalent to an episode of sudden death. Some ventricular arrhythmias terminate spontaneously. Appropriate ICD discharges are associated with worse near-term prognosis. Etiology of chronic cor pulmonale, diseases of the lung parenchyma, COPD like emphysema and chronic bronchitis, interstitial lung disease like idiopathic interstitial pulmonary pneumonias like IPF and UIP, secondary interstitial diseases, sarcoidosis, combined pulmonary fibrosis and emphysema, bronchiectasis, cystic fibrosis, pulmonary Langerhans cell histiocytosis, lymphangiomyomatosis, developmental lung disorders. Disorders of chronic alveolar hypoxia, alveolar hypoventilation syndromes like obesity hypoventilation syndrome, central hypoventilation syndrome, neuromuscular respiratory failure, chest pain disorders like kyphoscoliosis, chronic exposure to high altitude. Diseases of the pulmonary vasculature is pulmonary arterial hypertension, idiopathic PAH, heritable PAH, drug and toxin induced, associated PAH, and veno-occlusive disease. Chronic thromboembolic pulmonary hypertension, pulmonary tumor, thrombotic microangiopathy, and mediastinal disorders affecting central pulmonary vasculature. Etiologies of heart failure: depressed ejection fraction, preserved ejection fraction, and high output state. Depressed ejection fraction is coronary artery disease like MI and myocardial ischemia, chronic pressure overload like hypertension and obstructive valvular disease, chronic volume overload like regurgitant valvular lesion, intracardiac shunt, and extracardiac shunting. Chronic lung disease like cor pulmonale and pulmonary vascular disorders, non-ischemic dilated cardiomyopathy like familial genetic disorders, infiltrative disorders, toxin, drug-induced damage, metabolic disorders, viral like Chagas disease. Disorder of rate and rhythm is chronic bradyarrhythmias and chronic tachyarrhythmias. With preserved ejection fraction is pathologic hypertrophies, primary hypertrophic cardiomyopathy, secondary hypertension, aging, myocardial disorders, restrictive cardiomyopathy like infiltrative disorders like amyloidosis and sarcoidosis, storage disorders like hemochromatosis and fibrosis. High output states like metabolic disorders like thyrotoxicosis, nutritional disorders like beriberi, excessive blood flow requirements like systemic AV shunting, and chronic anemia. So coming to the NYHA classification, class 1 is patients with cardiac disease but without resulting limitation of physical activity. Ordinary physical activity does not cause undue fatigue, palpitation, dyspnea, or anginal pain. Class 2 is patients with cardiac disease resulting in slight limitation of physical activity. They are comfortable at rest. Ordinary physical activity results in fatigue, palpitation, dyspnea, or anginal pain. Class 3 is patients with cardiac disease resulting in marked limitation of physical activity. They are comfortable at rest. Less than ordinary activity causes fatigue, palpitation, dyspnea, or anginal pain. Class 4 is patients with cardiac disease result in inability to carry any physical activity without discomfort. Symptoms of heart failure or anginal syndrome may be present even at rest. If any physical activity is undertaken, discomfort is increased. So this is the NYHA classification. This should be on the tip of your tongue. So major causes of aortic valve disease are aortic regurgitation, a valvular or root disease. So valvular is congenital bicuspid aortic valve, infective endocarditis, rheumatic fever, myxomatous degeneration, traumatic, syphilis or ankylosing spondylitis. Root is aortic dissection, cystic medial degeneration, Marfan syndrome, bicuspid aortic valve, non-syndromic familial aneurysm, aortitis, and hypertension. So major causes of dilated cardiomyopathy are inflammatory myocarditis, infective like viral, especially Coxsackie, adenovirus, HIV, and hepatitis C. Parasitic like Trypanosomes cruzi causes Chagas disease. Trypanosomiasis, toxoplasmosis, bacterial like diphtheria, spirochetal like Borrelia burgdorferi, Lyme disease. Rickets, fungal with systemic infection. Non-infective like granulomatous inflammatory disease, sarcoidosis, giant cell myocarditis, eosinophilic myocarditis, polymyositis, dermatomyositis, collagen vascular disease, checkpoint inhibitor chemotherapy, and transplant rejection. Toxic is like alcohol, catecholamines, amphetamines, cocaine, chemotherapeutic agents like anthracyclines, trastuzumab, interferon, other therapeutic agents like hydroxychloroquine and chloroquine, drugs of misuse like emexidine, anabolic steroids, heavy metals like lead and mercury, occupational exposure like hydrocarbons and arsenicals. This is a continuation of the previous chart. Metabolic like nutritional deficiency like thiamine, selenium, carnitine, electrolyte disturbances like calcium, phosphate, and magnesium. Endocrinopathies like thyroid disease, pheochromocytoma, and diabetes, obesity, and hemochromatosis. Inherited metabolic pathway defects, familial like skeletal and cardiac myopathy, dystrophin-related dystrophy, Duchenne's and Becker's, mitochondrial myopathies like Kearns-Sayre syndrome, arrhythmogenic ventricular cardiomyopathy, hemochromatosis associated with other systemic diseases and susceptibility to immune-mediated myocarditis. Overlap with non-dilated is minimally dilated cardiomyopathy, hemochromatosis, amyloidosis, and HOCM. Idiopathic, miscellaneous, shared elements of above etiologies is peripartum cardiomyopathy, left ventricular non-compaction. Tachyarrhythmia-related cardiomyopathy is supraventricular arrhythmia and uncontrolled rate. Very frequent non-sustained ventricular tachycardia and high premature ventricular complex burden.